Good evening, everybody. We're in the heart of downtown Chicago, and you're all here, so you're a very disciplined audience. Thank you very much for being here, and thank you to the organizing committee for giving me an opportunity to talk to you about the challenges facing rural maternal health. I don't have any financial disclosures. However, I would like to acknowledge the support of the Health Resources and Services Administration and other organizations that have supported my work in my home state of Iowa. So these are my objectives, but I'm going to quickly skip through that because we are short of time. So I'm a bit short here, so I sort of can't see over the podium. But anyway. That's okay. Is that one here? Sorry. Okay. Okay. All right. My apologies for being a little bit short here. So one of the biggest challenges that we face in rural healthcare is access to quality healthcare. No, I'm fine, thank you. Thank you. So one of the reasons is because of rural hospital closures. So that's happening right throughout the US. And in addition to that, the OB units are closing down. And you might ask why, and that's because OB units are very expensive to maintain. They need 24/7 staffing, they need OR, 24-hour OR facilities, and in addition to that, usually these rural settings, the volume of patients are pretty low, and most of them are, or some of them are Medicaid patients, so that the reimbursement is also in turn low. And this accounts for the difficulty in financial viability. And so it's always, if a hospital is in trouble financially, it's the OB unit that's the first to go. So that's one of the problems with rural healthcare. And when a hospital closes, you'll find a hospital is there, but there's an ED, there's ORs which do other general surgery, orthopedic cases. There'll be a med-surg floor, but there will be no obstetrical services. So that'll be remaining in the rural setting. So this is my home state, Iowa, and you can see that there's all the negative or the stop signs sort of are the closed OB units. In the past 20 years, over 40 OB units have closed throughout the state, and 14% of women have to travel for more than 1 hour to reach their destination where their planned delivery site is. So that's a significant proportion compared to 9% of women throughout the US that have to travel that long. So Iowa being a rural state, you can see that how much of a distance that women have to travel to their destination for delivery. So I'm going to skip over this because many eloquent speakers did talk about maternal care deserts before, but this is, as you can see, it is a national trend, and it's not only that, it is a global trend. So this is a recent study that has been just published just last month, and it shows the correlation between maternal mortality ratios as well as maternal care deserts. And the description is not really very reflective, but there is a parallel between the two. And the statistical analysis, of course, is significant, though you can't really very clearly see it on this diagram. So I'm going to go back to what remains, and what remains is the emergency departments with no supporting OB units in these hospitals where the OB units have closed. And the other level 1 hospitals, which are the lowest resource OB units, those are the other hospitals that are remaining in rural areas. So why I stress this is because these are all low volume hospitals, and let me tell you why. So some of the other challenges to direct patient care are that in these hospitals or these units, personnel usually have limited specialized training. And what I mean by that is you wouldn't get obstetricians here, but you would get generally family practice physicians who have had extra OB training. The low patient volumes, which I stressed before, that means that there'll be infrequent exposure to obstetric emergencies, and that means that there's difficulty maintaining skills. In addition to that, none of the specialists are in-house. There are no OB specialists in-house, and neither are there any anesthesia providers in-house. They're all outside, and they come in when needed. Now, during after hours, things get worse. So staffing is minimal. Now, when we consider a rapid response team, there'll be so many people coming in that we'd have to say, you know, some of you all need to go out. There'll be so many experts coming in. But unlikely, in these hospitals, usually a rapid response team is the labor and delivery nurse, the unit clerk, and maybe the house supervisor, and in addition, maybe somebody coming up from the emergency department. So that's all you have in a rapid response. That's all you have during an emergency. Now, in addition, other critical resources. When we talk about hemorrhage, we talk about massive transfusion protocols. In these hospitals, there's like maybe 6 units of O-negative blood. And you probably have your unit clerk who can either go and fetch the blood or go and do the laboratory investigations. You can't have him doing both. It's one or the other. So you can see that the resources are lacking in these level 1 hospitals. So this was the plight that my state was faced with. And this was in around 2019, and that was before we became an AIM state. So our public health department, as well as our OBGYN department, applied for a HRSA grant, and we got that. And I was a part of that I was a small part of that very large grant, and this is what I was tasked with. So I was told, okay, develop a education module so that you can help maintain clinical skills in these rural hospitals. So this was our innovation. We developed a mobile simulation unit that went right throughout the state, and we taught obstetric skills to our rural hospitals, as well as those emergency departments which were lacking in the OB units. So this is what we did. We did several needs assessments. We purchased equipment. We gave equipment to all our facilities. We trained trainers in each of these facilities. We designed a curriculum, and we physically visited all the EDs that didn't have OB units, and we visited the level 1 OB units. So that's the vehicle we bought, and I can tell you a billion stories about that. I was given a free rein on what I wanted to do with this, with this program, but I was not given a free rein on what vehicle I could choose. So this is a Ford 150 pickup truck, and I have to tell you, it was not my first choice, but it is Iowa. So Iowa and Ford pickup trucks and cornfields, that's where I come from. So anyway, this is what we did. And I'm going to tell you a little bit about the curriculum. So for our emergency departments, we had to do didactics as well as skill stations, because our emergency department colleagues, they had either forgotten their physiology or probably didn't have physiology and anatomy, or maybe have not had that amount of training. So when we talk about fundal massage, then sometimes the question comes up, okay, where is the fundus? Or even, what is the fundus? So we really had to do didactics, pretty extensive didactics, before we went in and did the skill stations. So Our skill stations were performing normal deliveries, active management of the third stage of labor, and really stressing on the uterotonics, and also recognition of postpartum hemorrhage, recognizing severe preeclampsia, managing eclampsia, and of course stabilizing and transferring the high-risk OB patients to higher care centers. Now, for what we did for the OB units was a little bit different. So we collaborated with our Iowa Perinatal Quality Care Collaborative, and we did our simulations in tandem with the bundles that they were teaching on for that year. So up to now, we have completed 2 bundles, the severe hypertension in pregnancy bundle and the obstetric hemorrhage bundle. And now we are in the maternal mental health and maternal drug use disorder bundle. So I was pretty successful in designing the simulations as appropriate for the first 2 bundles, but the maternal mental health bundle has been a challenge. It is very difficult to create simulations or even communications modules on this, because I am always conscious about triggering traumatic events in even my providers or even the standardized patients. So it's been a challenge, and actually my colleague Tracy has given me a lot of good pointers which I can use going forward. So the good thing about partnering with the Perinatal Quality Care Collaborative is that we are giving the same information to all the hospitals. So the care is standardized right throughout the state in Iowa. And not only that, the information is always up to date, and it is always best practices. So that's what, so instead of doing simulations just ad hoc, partnering with the Perinatal Quality Care Collaborative, I think is a very, very smart move. Standardization right throughout the state, I think that's key. So I want to tell you a little bit about the simulations. So the simulations were all in situ because we actually traveled to the sites. And we used the equipment that were available in the labor and delivery suites, and we used their protocols. And now, I want to address the fact that the main OB providers or the anesthesia providers, they're not in-house. So we often stressed our simulations along with communication from for the nurse who's at the bedside, and we taught them to communicate with the providers who are outside. So essentially using S-bar as a tool to communicate and convey the condition of the patient to the provider who is outside and get orders or whatever preparation that needs to be done, so that when the provider comes in, say for example, the provider wants to put a Buckley balloon or a Jada balloon, the nurses would be ready, would have that all ready, even the glove size and everything ready, so that the provider comes in and immediately does what he or she needs to do. So we often stressed on that kind of aspects because of those challenges in these level 1 and other rural settings. Another thing that we did was we always brought in all the teams, including unit clerks, people from personnel from the EDs. They would all come for the simulation, but it is not very common for us to get OB providers or even anesthesiologists to come for our simulations. So I want to show you our ED sims. So we went and did simulations in hospital bays, EMS and transports, and fire stations. So we've delivered in the back of ambulances, and you can see this is in a fire station. So this person you can see right here with the mustache, he's a big burly guy, and when we first walked in there, he said, "I'm not gonna be doing any one of these things," and he just went away. And we were there the whole day doing simulations, and by the time the evening rolled around, he came back and said, I think I want to try this. I want to do a delivery. I said, okay, go ahead, do it. And then the next time around, I said, no, I don't want you to touch. I want to do it all by myself. So these are these huge hunk of a guy who first said, I don't want to have anything to do with simulation, but came around and then did it. I also have a really cool picture of me on the back of the rig, but I'm going to spare you that, and instead, I put this other one. If you can see in the corner there, can you see all the boots and the trousers and the jackets and the hats? So when there's an emergency, the firefighters would come in, they would go into the booths, they'd pull up their trousers, put on their jackets, put their cap on, and then they go out. And so much of preparedness. I thought that was just fantastic. I felt very honored to be able to go to their domain and to be able to share what I knew with them, and they shared what they knew with us. And it's truly a privilege to serve these folks who look after us at other times. So this is our reach, and I can very proudly say that I have really traveled to every corner of my state and it's actually even more lines now because this was from last year. We do a tremendous service in going to every part of the state. And as I said, the information we give is always the ones that's up to date, and it's the standard of care, and it is the same standard right throughout the state. So sustainability and where we are today. So now we are in our second Maternal Health Innovation Grant, and earlier we had an Iowa Maternal Quality Care Collaborative, but now it is a PQC, it's a Perinatal Quality Care Collaborative. We have consolidated our AIM coaching and our simulation team, so we don't have a separate simulation team now, but we have both together, so the coaches are also the simulation experts. And that makes for a lot of common sense because the coaches go in there and they see what the challenges are, and then they do the simulation, and then they can follow up on it. So that just makes total sense. And now that we have done most of the key to both of the key bundles, we also offer simulation from a sort of like a menu. If a facility has had a challenge, then they can always tell us, okay, hey, we want to, do a sim on this particular, maybe it could be a cardiac arrest or an anaphylaxis, and then we would, create that simulation for them, and then they would be able to run it. So recently, we are collaborating with Sim Iowa, and Sim Iowa is another simulation program that's right throughout the state, and it's run by the College of Nursing at the University of Iowa, and it's through a Wellmark grant. And just last Thursday, we went and we had our initial meeting, and you can see that Sim Iowa has these big trucks, and they actually not only take simulation equipment, they take the simulation space also when they travel, and there are 3 trucks that are spaced right throughout the state. So we will be collaborating with them and that's very specifically to go to the maternal deserts. So those are the hospitals where there's only an ED, but there is no OB unit. So I really speeded things up, so hopefully you got all caught up with time. Whenever I go for these simulation visits, I'm often asked, okay, so I introduce myself and I say I'm an anesthesiologist. And when I say that, and people will ask me, okay, so you're an anesthesiologist, so what are you doing here with these OB stuff? And then I tell them, yeah, well, do you do your anesthesia stuff? Do you do stuff in the OR? And I said, yeah, I'm an OB anesthesiologist. I'm 100% clinical. I practice anesthesia all the time. But you all would be surprised that us anesthesiologists, we have a lot of other talents. We are very skilled. We do simulation. And, I'm probably speaking to the choir here because patient safety is something that we are leading in. And there's so many aspects that we do. We are leaders, and this whole program, I put it together. Quite a lot of it was my creation, and it is my skill as an anesthesiologist, I think, that has reflected on other skills that I have developed. So I though I'm going to put this next slide up. And as I said, I may be preaching to the choir, so forgive me if I'm doing that. But I want to reflect on what specific skills or expertise that we have as anesthesiologists that can bring about and help practical and bring about practical and sustainable solutions, not only to improve maternal care, but to do improvements in so many other aspects that we talked about. And today we talked about so many of those skills that we all have. And as I said, you know, I always want to bring myself out of the OR. I think we are all fantastic in the OR, but we do also fantastic things outside of the OR, within our community, within our state, within the whole country. And I think the key problem now is, you know, how do we get this message out of this room? We all know this, but we need to tell this to the rest of our anesthesia community. So that's the question that I would like to leave you all with for self-reflection and see how can we get this message to all of our anesthesia colleagues that we've got so much more skill. We are fantastic in the OR, but we are fantastic outside as well. Thank you very much.